for themselves. Again, these were highly selected patients, and unlike the 2009 studies, I think the two groups there were better patient selection. And presumably it wasn't just this periosteal wasn't so random. They presumably did it in a consistent fashion, and they themselves say the results suggest that periosteal infiltration alone in the early phase provides enough pain relief with no need for additional cementation. So it seems like they're suggesting that should be one of the treatments that are tried and fail before vertebroplasty.
Yeah, and I don't think I'm knowledgeable enough about Vertos 4 to respond to that reasonably, but I would say I'd still go back to these clinical pathways and say I think you're throwing out the baby with the bathwater. You're saying let's do a trial and treat them all like this when you're not going back to these unique combinations of findings in these patients. And just like you pointed out, I think bottom line, patient selection would be essential. I would be very careful not to treat a fracture that has caused kyphosis, caused postural change, caused, all of the known problems we have with osteoporotic vertebral fractures, and try to stop the pain with a bupivacaine injection when you're not treating the other problems.
Okay, Dr. Chambers.
I don't think that would be appropriate.
We've got people stacking up in the queue, so we're going to have to get to that. But I would just remind people that the question here is about the interval. Assuming that we agree that augmentation is useful, it's about the interval that should precede. Does the fracture have to be acute? Can it be subacute? Can it be chronic?
And may I ask, I don't want to take too much time, but Dr. Hirsch, you're probably much more familiar with how the intervals were addressed in the RAND UCLA appropriateness method paper, and I think they were divided 0 to 1, 1 to 3, 3 to 6, and greater than 6. Again, could you explain how that factors into the multiple combinations of treatment, and if you think that publication addresses that adequately?
Thank you, Renee. I think you took over the job of co-moderator. I want to be respectful. I want to be respectful of the fact that we have a lot of people in the queue. I'll say two quick things related to the questions that have been posed. The first is, and I would make people aware that there is some background noise that is probably best by people muting their phones so that we can be respectful of all the people that are on the call. So if you're not muted and not speaking, please mute yourself. With respect to the RAND, the RAND study, we looked at multiple different parameters, and it was actually a surprising consensus opinion and a strongly held consensus opinion that timing should be deemed less important than these other factors. With respect to the question that Dr. Chambers was answering for Dr. Hogg, I think we can simplify Dr. Hogg's question, which is that if the sham trials demonstrated that the active control sham did better than expected, would that be a reasonable step on a clinical care pathway? Not one that was employed in the RAND UCLA trial, but one going forward. I have my own biases on the answer to that question, which I've actually shared with Dr. Hogg, but I think we should throw that back to subject matter experts.
Thank you. Operator, if we could open the line for the next commenter.
Your next question line of Dr. Jeffrey Coe.
Yeah, hello. Can you hear me?
Yes.
Yeah, I'm an orthopedic spine surgeon in California. Represent the California CAC. I have no current conflicts, although I did participate in the CAST trial about 3 to 4 years ago and got some research support, but again, no current conflicts, except for the fact I take care of patients with fractures. So far, I believe I'm the only orthopedic surgeon that has spoken regarding this. And the principles of fracture care have to be kept in mind, and I think there's meta-analysis and other studies that suggest the mortality rates from vertebral compression fractures approach that of hip fractures. And I think we have to understand, and I want to reiterate the comment of the endocrinologist colleague that spoke earlier, that this is a heterogeneous population. And I think all of these studies, including this recent Vertos studies, but particularly the two very disproportionately high impact trials in 2009, Bookbinder and Kalmus, although they're randomized controlled trials, we've been seduced by the fact that they're randomized controlled trials published in prestigious journals. And the reality is the definition of evidence-based medicine is high-quality randomized controlled trials. And I venture to say, and I'm disappointed in my own academy for not calling these out, that these are low-quality trials with severe methodological flaws. The point that I'm making here is that who, in their right mind, having severe fracture pain, is going to make a flip of the coin decision on whether or not to participate in a trial like this. These trials, I admire them for trying to do these trials, but they're very difficult. And I think the same probably applies to the more recent trials. The trials that you want to look at for clinical evidence are trials that follow all patients that are either enrolled or not enrolled, and what happens to those, much like the sports trials that looked at disc herniations. And I know we were discussing science and anecdotal evidence in general, but the reality is if it doesn't pass the smell test, something's wrong. Fractures hurt. They're painful. And granted, some are less painful than others, and some have various stages in healing when they're diagnosed. But a 101-year-old grandfather of my nurse practitioner was misdiagnosed for whatever reason. He had severe pain. He had a relatively minor incident, and he was on opiates and died nearly of a respiratory arrest until he was finally appropriately diagnosed and treated with a kyphoplasty. This was just last week. These are life-saving procedures in patients. So, and if the science is bad, we need to reject the bad science and move forward.
So, Dr. Coe, let me ask, related to the question on the table, how long would you require non-surgical management before proceeding to augmentation?
Very good. And the point I want to make, it depends on the patient and the clinical presentation. If a patient is in acute pain and can't move, has impairment of ADLs, has very poor scores on ODI, or what other clinical measures you use, you will treat them more urgently. If they present with relatively minor pain, they're more functional, then you can wait and try bracing and other measures. So it's a patient selection issue. Again, the point I made earlier, this is a heterogeneous population, and it's a variable thing, and I will offer this.
Although I would say I think most of the studies have at least been moderate to severe pain. They haven't included minor pain.
Well, I understand that. But pain is subjective, unfortunately, and what one patient perceives as severe pain is maybe more tolerated by others, and some folks will minimize their pain for various reasons because they don't want to be a burden on their family.
Are you suggesting if they're reporting it as mild, that we should still consider them a potential candidate?
Well, not necessarily. It depends upon other factors. If a patient says their pain is mild, but they're stuck in bed and can't get up, so I'm not going to get out of bed, it hurts too much, but my pain's only a 2 out of 10, I'm not necessarily going to believe them. If their ADLs are impaired and the fracture anatomy is appropriate, they have the appropriate imaging study. So this has to be handled on a case-by-case basis from the point of view of active clinical practice. But from the point of view of the science, we have to be very careful about not getting seduced by randomized controlled trials that are published in prestigious journals, because quite honestly, the editors and reviewers...
I think we've covered the deficiencies. Yeah, I think we've covered the deficiencies. You don't necessarily need to go over that. But sticking to trying to talk about the length of non-surgical management, as I mentioned in the beginning, I think most of the Medicare policies require 6 to 12 weeks approximately of after 6 to 12 weeks of non-surgical management. Clearly, there are some that you would do immediately. Is there would there be any that you would wait on 6 weeks or 12 weeks on?
If a patient was functional, if the patient responded to, let's say, bracing and non-opiate medication, they didn't have significant deformity, and I would say this is a reasonable option. This fracture will heal.